Division of Interventional Pulmonology, Fortis Memorial Research Institute, Urogram. Transaortic Ebus fine needle aspiration. A 31-year-old male patient with a known case of chronic kidney transplant rejection presented with complaints of fever and significant weight loss for a 1-month duration. A non-contrast CT scan of the chest showed an enlarged lymph node measuring 20 mm in diameter at station 6 paraortic location. Sequential EBUS scanning enabled the identification of a lymph node at station 6 across the aorta. A 22-gauge needle was used to perform EBUS-guided transaortic fine needle aspiration of the lymph node. In the first pass, the needle tip failed to reach up to the distal wall of the aorta and remained within its lumen. We then had to reposition the EBUS scope to access the minimum diameter of the aorta, which enabled us to penetrate the needle through its walls into the target lymph node. The needle was agitated 10 times across the aorta, ensuring that the needle tip remained within the lymph node to prevent repeated puncturing of the aortic wall. The MGS stain of the lymph node aspirate showed a background of necrosis and a few lymphoid cells. ZN stain showed beaded acid-fast bacilli, establishing a diagnosis of tubercular lymphadenitis. Transpulmonary Ebus-guided. A 30-year-old male presented with complaints of fever and significant weight loss for 6 weeks. A CT scan of the chest revealed multiple enlarged enhancing lymph nodes, the largest measuring 18.5 mm at station 5 prevascular location. Sequential EBUS scanning enabled the identification of multiple lymph nodes at station 5 across the pulmonary artery. A 22-gauge EBUS needle was passed and agitated several times through the left pulmonary artery into the target lymph node. ZN stain of the lymph node aspirate showed beaded acid-fast bacilli. Transvascular Ebus-guided. An operated case of CA larynx presented with a suprahilar PET avid lung nodule measuring 2.5 by 2.8 centimeters. The azygos vein was localized at the 10R station location. The azygos vein was seen merging with SVC. The lung nodule was seen just under the arch of the azygos vein. The EBUS needle was passed through the azygos vein into the lung nodule. The needle was agitated 10 times within the lung nodule while maintaining the path of penetration constant to avoid laceration of the vessel. The needle aspirate from the nodule showed atypical cells suggestive of poorly differentiated carcinoma. The transvascular EBUS-guided needle aspiration should be performed only as a last resort when other diagnostic modalities are either not feasible or have failed to establish the diagnosis as a necessary evil.